Dr. Siba Haykal is a plastic surgeon at the University Health Network and assistant professor at the University of Toronto. Her clinical focus is on complex oncological reconstruction and microsurgical reconstruction of the breast, head and neck, and extremity. Our presentation is titled Breast Reconstruction Using Your Own Tissue. Dr. Siba Haykal, Breast Reconstruction Using Your Own Tissue.
Thank you so much for having me here today. So breast reconstruction using your own tissue, also known as autologous tissue. It essentially means using the patient's own tissue to create a breast mound. It avoids the complications related with implants and has a pretty acceptable donor site. So where can we take this tissue from? There are several areas that we can take it from. Most commonly is the abdomen or the tummy. And these are described as either a pedicle tram, a muscle-sparing tram, a Dieppe flap, or an SI8 flap. There are other areas that we can also take it from, such as the buttock, the thigh, the groin, and the back. So if we look at this picture, so the Dieppe flap comes from the abdomen or the belly. The tug flap comes from the inner thigh. The SIEA also comes from the belly. The Tdap or the latissimus dorsi comes from the back. The S-gap or the I-gap comes from the buttocks. And the PAP comes from the medial posterior thigh. The most common ones that we will hear about and most common ones used are the tram flap or the Dieppe flap. The tram flap, which in this case right here is a pedicle tram, involves taking skin and fat as well as a portion or the whole muscle and transferring it or rotating it into the breast to create a breast mound. Another option is a Dieppe flap, where we take tissue and skin and fat and we disconnect them from the belly and we reconnect them into the chest. And I'll talk a little bit more about that. So this is a cross-section of the abdominal muscles, so the muscle in the tummy. These vessels are small little vessels that are less than 1 to 2 millimeters in size. So initially, when we discuss this surgery as a possibility, we do imaging and a CT scan to look at whether or not these vessels are available. And what we do during the surgery is we find these vessels, we follow them down to the bigger vessels in the groin, we disconnect them, and we reconnect them under vessels that are located under a small piece of rib that we have to remove. So we use loops and a microscope to put these together. You end up with a scar from hip to hip and a scar around the belly button, similar to getting a tummy tuck. There's also scars located over the breast, and I'll show you examples of what these would look like. So typically with a Dieppe flap, which is a free flap reconstruction, one side takes about 6 to 8 hours. Both sides take about 10 to 12 hours, and the hospital course is about 3 to 4 days. The first 24 hours are the most important because that's when we watch the blood flow to make sure that the vessels that we connected are working well. And for that, we use monitoring devices to do that. So these monitoring devices include a Doppler and certain other external devices that we can use. What are the possible complications? More often than none, there are no complications. However, we are operating within the abdomen, within the muscle, and sometimes there's a small risk of a hernia or a bulge. There's also a small risk of losing the blood supply to a portion of that flap. There's also delayed wound healing, a possibility of infection, a possibility of a hematoma or a seroma, which is a blood collection or a fluid collection, and sometimes we can lose viability to the whole flap. Although that is rare, it can still happen. This is an example of a patient who had an immediate DF flap reconstruction. So in this case, this patient had a mastectomy through a circular pattern where the nipple and the areola were removed, as well as all of the breast tissue, and the skin envelope was left behind. So we took skin from the abdomen, we disconnected it, and we reconnected it. And at the same time, we did a bit of a breast lift because there was a bit of excess skin. This is another example, and in this case, because of the tummy tissue was slightly bigger, the patient ended up with a larger reconstruction than her initial breast size. This is an example of a patient who had cancer only on one side, and we used the abdomen or the belly tissue to reconstruct the breast, and we did a lift and a reduction on the other side to help these two match. A delayed reconstruction is a reconstruction that is done at a separate operation after the mastectomy. So that can be months to years after. So this is an example of a patient who came in with 2 scars following mastectomy several years after, and we used the abdomen in order to reconstruct. And if you notice, compared to an immediate reconstruction, the scars look different. So in the case of the immediate reconstruction, the scars looked like a circle. In this case, we did not have that skin to work with, so we had to borrow more skin from the abdomen and expose more skin from the abdomen, and therefore the scars look more like an ellipse. So autologous reconstruction has the advantage that most of the reconstruction can be done at the same time as the surgery. We're using your own tissues. It's lifelong. It's the best substitute for natural-looking breast. And some of the benefits, especially from the DIEP, is a tummy tuck. The disadvantages, however, is it's a longer procedure, it's a longer recovery time, it's a separate donor site, it may require revision surgeries, there's a possibility of losing the flap, the abdomen can only be used once, and all the other areas can only be used once. And there's more scars, so there are other areas, there's more scar burden. There is another option of using your own tissue in combination with an implant or a tissue expander. This is an example of the back flap or the latissimus dorsi flap, where we take skin and fat and the muscle from the back and we swing it over to the front in combination with an implant or a tissue expander. This is done, for example, in cases where we lose part of the breast, so a partial mastectomy or a lumpectomy, and we can use that in combination with an implant in order to augment the breast and to give it a nice shape. Other options are following mastectomy, where we take skin and fat and we bring them over in combination with breast implants in order to reconstruct the breast. And the advantages of this is that we can use this in patients who are interested in having implant-based reconstruction but have been previously radiated to potentially reduce the risks. We can also use it in patients who are either too thin or have had previous abdominoplasty or a tummy tuck. The disadvantages is that it comes with all the risks related to implants and all the risks related to using your own tissue from another part of the body. How do we determine what is the best option? It's about patient preference. It's about needing post-operative treatments such as chemotherapy or radiation, the availability of the donor site, other medical issues, and recovery time, and that's why it's important to speak to your healthcare provider about the best options for you. Thank you so much.